anymore, so my voice has gone down quite a bit, and I'm not allowed to yell at my grandchildren, so that's what I have grandchildren, yes. Okay, so while this is getting set up, I think the original title of my talk was a comparison of the metabolic abnormalities in KAT6A and KAT6B. And I've changed the title a bit because it's pretty boring. There wasn't there really there are differences that would mean something only to a biochemical person, and as far as I can tell, have no relevance to treatment. So what I focused on, and so I'm now essentially considering KAT6A and KAT6B from a treatment standpoint, from how do we correct the abnormal metabolism as identical syndromes, hence the revised title. So this is just a short list of the metabolic abnormalities that we now recognize. I just found another one that I don't have enough data on to report, but it looks very interesting. We suffice to say that we can identify metabolic abnormalities and know how to treat them, but and we know that of course they are related to abnormalities in histone acetylation, but the nitty gritty of how the changes in acetylation lead to these specific abnormalities uh, cannot fully explain. Certainly there's evidence that the citric acid cycle is not working very well, and that happens in a number of mitochondrial diseases. So we have some experience with treating these. And in fact, if I could ask, how many parents just have not been to one of these conferences before? Oh, quite a few. Okay. So I've given some of this information before, but I think there's enough people who would benefit from it. I can't see my screen. Let's see if that was better. So the primary, what as I've said before, I first treated a child who had evidence of mitochondrial dysfunction before her genetic diagnosis was known, and was only later when actually Dr. Esberg came to me and said, I want the same treatment that you gave so and so. And I said, what do you mean? And I hadn't known that since I had advised the treatment to her doctor. I said, try this, and it did help. So then that led to Dr. Esber, who has a son, Peter, contacting me, and that. So we started looking in more detail. I was glad that the treatment helped, but I wanted to understand what we were treating. So what I'm discussing here are very specific studies looking for treatable metabolic abnormalities, and that's my expertise, is to identify metabolic diseases and figure out how to treat them. So this was fairly standard fare for me, and the certain of the abnormalities it was obvious how to treat them. Other ones came up later. So what they are, the amino acid abnormalities, which I'll show in the next slide or two, were very puzzling at first. And it was only after we had studied about 20 patients that they began to make some sense. Um, we also identified a very severe deficiency of citric acid that virtually all children, I shouldn't say virtually, probably 95% of KAT6A children have. They have low levels of citric acid, which is the same as citric acid that you get in citrus fruit. But the body makes a great deal of citric acid, and that's one of the signs of their lowered citric acid cycle function, that they don't make enough citric acid to supply the many different metabolic pathways that use citric acid. And it turned out that was because I dealt with citric acid deficiency before, we then recognized that this deficiency was the primary cause of the intestinal dysmotility that I'm sure many of you have dealt with, and it can be extremely severe, causing what's called pseudoobstruction and intussusception, and it has led to multiple surgical interventions, and unfortunately, even a few deaths when the process was not appreciated. Another thing that came up because it relates to other types of mitochondrial dysfunction is a deficiency of methionine, and this is where methionine is it's a normal amino acid in the diet in protein, but the distortion in the function of the mitochondrial citric acid cycle causes methionine to be shifted away from protein synthesis and into the synthesis of another compound, creatine. And so the children become methionine deficient. And unless that is recognized, and it's not easy to recognize that, as the amino acid levels in plasma can be normal. But if you look further, you see that there actually is a deficiency. And this causes bone marrow failure. And it also interferes, it causes an anemia, and it also can cause bone marrow failure in the most severe cases, which is only a couple so far. There's an increased need for certain vitamins, largely because when amino acid metabolism is distorted, or with any kind of metabolism is distorted, there are the mitochondria or the cell they use sort of rescue mechanisms to deal with the deficiency or the abnormality, and that those mechanisms then need extra. They might need extra more than is usually needed. So that was the cause of methionine deficiency. But the same problem occurs with certain vitamins, especially B6, and B5 is, in a sense, it's insufficient. It's not deficient. It's insufficient because now we know pantothenic acid augments the production of acetyl-CoA for making for acetylene histones. And the principle there is that if you have an enzyme deficiency, increasing the amount of the substrate, what the enzyme works with, can make a reduced amount of enzyme activity almost compensate for the primary abnormality. And fortunately, in KAT6A and KAT6B, there's usually, virtually always, one normal copy of the protein, which is an enzyme, and therefore you're dealing with 50% normal activity, which we know is not adequate, but it doesn't take all that much to stimulate, to produce extra acetyl-CoA, which is what the enzymes use. We can manipulate that and increase that by very simple means, and therefore restore either completely or partially, at least, the function of KAT6A. So it's almost like doubling, it can be almost like doubling the amount of KAT6A, so you're back up to normal. And again, I speak more of KAT6A, but that's what I've dealt with more, but anything I say applies to KAT6B. And then there's mitochondrial free radical damage, which is, I think probably most people have read of that in the lay literature. It doesn't happen to all children, but it's often enough that we have to look for it in each child, and also look if it develops later. It can develop. It usually is not present in the first few years, and what we measure biochemically is evidence that the mitochondria have been progressively damaged by so-called free radicals, which are their production is increased in many different conditions where mitochondria don't work very well. Okay, so these are the basic treatments. I've explained some of these as they are. The it just was fortunate that there's an enzyme pyruvate dehydrogenase which has been known for decades as a primary disease. It can cause it's a mitochondrial disease, and I think the first patient I had with that I treated was 40 years ago, and we had learned back then that using pantothenic acid uh, and carnitine could augment the residual activity of that enzyme, as well as adding thiamine. And so we had experience with how to increase the production of acetyl-CoA by experience with that enzyme deficiency. And as it turns out, the most of the acetyl-CoA that KAT6A and KAT6B use to acetylate histone is made by the same enzyme that instead of being in mitochondria, a portion of it has been shifted into the nucleus, where the same enzyme, we can use the same mechanisms for stimulating the pyruvate dehydrogenase to make increased acetyl-CoA. And it works very rapidly, and that's why some of the parents here have seen changes almost overnight when you start carnitine, and especially carnitine, but pantothenic acid augments the effect of carnitine. And then again, it varies. Many of the children with KAT6A in particular are on citrate, and that has been it certainly has helped Peter a great deal. But other parents have also said the same thing, that it can eliminate the dysmotility. Most common evidence that is just severe constipation. There, I have in the past used. I'll make that point later when I show you a slide. The mitochondrial antioxidants, again, we have decades of experience in how to treat and minimize the adverse effects of free radicals. So the first child who I treated, who I didn't know had KAT6A, that was what she was given based on simply her biochemical findings. And then there's an issue about these enzymes also use other compounds, propionate in particular. And one of the considerations is that if we are stimulating the activity of KAT6A in part by increasing the amount of acetyl-CoA, that might, in a sense, interfere or reduce the effectiveness of the enzyme in putting propionate onto histones, and they have different functions. So that's something which needs to be addressed somehow in a protocol to see if we could, if supplementing with propionate or something that generates propionate would help. I imagine some children here are on probiotics, some of which you may read on the label. It says propionobacterium. So some of the children may already be getting a propionate source. So this is just to show the confusion that we had at the beginning. This is the first 28 children showing the amino acid abnormalities on a z-score graph, so that that's the normal range basically. So anything above or below would be considered abnormal, not necessarily pathological, but abnormal. And as you see, it took a number of patients. It took all 20 or 28 patients to see that there was an abnormal distribution. Citrulline is the most obvious abnormality, and asparagine not as commonly, but also but just that was they're both in the citrulline in particular is involved in processing of nitrogen, and there are other reasons to think that that is part of the abnormality that occurs. Again, the fundamental issue is downregulation of the citric acid cycle. So these are consequences of that. But the variability in patients is shown by this. For example, the citrulline, most patients have, they're on the high side. This high proline and high alanine in particular, they are signs of a more typical type of mitochondrial dysfunction for which we need to use antioxidants. And there are some other characteristics in this in these data, but it's one of the something that's sort of slowed down and making more rapid progress is that the so much variability in looking at amino acid levels, and they are much more um, sensitive to identifying types of mitochondrial dysfunction. But they're also, amino acids are also dependent on a child's diet. So there are many confounding factors. And it's probably many parents have been told, your child's amino acids are normal. Dr. Kelley's crazy. And that's because um, it's just the way that the amino acids are measured in laboratories are they don't use the right controls, and so that the normal range is abnormally wide when you want to think about mitochondrial function. So we a special method for analyzing the ratio of an amino acid to all other amino acids. That's a more sensitive way. So yes, amino acid study can be completely normal, but that's why I always want to see the actual data because the interpretation, the laboratories aren't looking for this, nor do they have the right standards. So where are we? Okay. So this is just to show the pyruvate dehydrogenase, the enzyme here. So pyruvate comes in from metabolism of glucose mostly. So there's ample pyruvate in most cases. Acetate is also produced from the citric acid cycle. So these both get into the cell and get into the nucleus. But from a quantitative standpoint, it turns out that pyruvate is more important than acetate. And that's why the treatment with carnitine and other things that stimulate pyruvate dehydrogenase works so well to increase the amount of acetyl-CoA in the nucleus, which is, of course, where KAT6A and KAT6B work. Just to remind everyone, I'm sure you've all memorized the citric acid cycle, but the what I'm pointing out here is that uh, the reason we focus on amino acids, that if you can see, almost all amino acids go through the citric acid cycle. So if the amino acid is not used for making protein, then it's used for energy and or for making other compounds, and therefore it has to. And the way that is done is to convert it to a different compound in the citric acid cycle. So when there, for example, the asparagine level is high in many children, and that's because the citric acid cycle function is reduced and it can't use as much asparagine as it normally would. If we could measure oxalacetate, if we had measured oxalacetate, this would have been high just based on our experience with other mitochondrial problems. But this is why we look at the amino acids carefully, because at this special timing, the functional abnormality of mitochondria is reflected in the amino acid levels. The amino acid levels in plasma are regulated by mitochondria. So, and if you catch the mitochondria, catch the nutrition at a neutral point, which is 4 to 5 hours after breakfast is our standard and before the next meal, that's where all the amino acids are more or less in equilibrium. And at that point, then one can make sense. One can look at the amino acids and say, this is what's wrong with the child's mitochondria, and then base your treatment on that. Very few, I should say, most geneticists don't do this, and that's why you will usually be told there's nothing wrong with your child's amino acid levels. This is to show the importance, the other consequence of the downregulation of the citric acid cycle is that citrate is made by the citric acid cycle. So asparagine goes into oxalacetate, and that combines with acetyl-CoA citrate. So again, if the asparagine is increased, it's another sign that the oxalacetate is not being converted into citrate. And indeed, when we measure citrate, it leaves the mitochondria and goes into the cytoplasm, then eventually it goes into the blood. When we measure citrate, it is low, as evidence of the reduced function of the citric acid cycle. And it just isn't in the medical literature that citrate deficiency causes intestinal dysmotility. And I've tried to convince a number of GI doctors to actually prove that, because they have all the patients. And I can't, so far I've failed in getting a GI specialist to study this, because they have lots of patients with dysmotility. And almost all children who have mitochondrial dysfunction and dysmotility, which is not all, have low citrate levels. It's very common and easily treated. So this is something I brought up last time, and this is the idea that there appear to be some children with gain of function mutation. And here are two children, and I think these are both KAT6A. I think any parent here would say these do not look like typical KAT6A children. They don't have microcephaly. They in fact have normal size to slightly large heads. They have this tall forehead, and they don't have malformations, or at least I haven't heard of any yet. And there are 4 patients whom I believe have gain of function, which is difficult to prove. But again, this is where the reason I consider them gain of function is their biochemistry. And I think most geneticists would look at this mutation here and say, it's impossible. That can't be gain of function. It's a truncation mutation like most KAT6A, but it's an early truncation, which makes difference. It makes a difference. So here, the basis, what made me think that, first of all, I should say that it's not surprising there is gain of function. Most genes that are associated with a genetic deficiency, certain mutation can cause an excess function. So that's very common. It's usually a small percentage. But there's some disorders where they're all gain of function, but in most cases, just a small fraction. So I wasn't specifically looking for this, but in one, I forget which one was the first one, but I think it might have been this child who had the opposite biochemical pattern, a high citric acid level, 4.1 with the upper limit of 3.7, and low level of citrulline, sort of the opposite, the flip. It's the flip side of the typical pattern. And the reason I feel that the citric acid level is, or that these children constitute a separate type of KAT6A is that one, they look similar, and two, there's no overlap. I have never seen. I'm not sure what the highest level of citric acid I've seen in KAT6A, even in mildly affected children, but it's never towards the upper limit of normal. So there's phenotypic way the children look, and there's biochemical evidence that this is different. And from a genetic standpoint, for looking at the genes, here's one of them. It shows that the the more organized functional parts of the KAT6A protein are these coil regions, not that the outer parts will have some has function in interacting with other proteins. But this is right in one of the important structural portions of the protein. And I listed here where these apparent gain of function occur. And one is a missense mutation late in the sequence, um, which should, I won't go into the details, but this should be able to persist as a synthesized abnormal KAT6A protein. And just because the protein is abnormal doesn't mean it's going to lose function. And the other two of the other ones are here. For example, this one is the mutation that it has a longer name, but is a truncation. It should cause a truncation in the protein, but it happens to bind to a newly identified region of the gene. It's called the winged. There are two winged helix domains, and I discussed this with Dr. Voss, and she agreed that this is. She couldn't agree that it was a gain of function, but she agreed that this is the type of mutation that could cause a gain of function because if it affects this, for example, affects the zinc finger region of the protein, which binds directly to the DNA. So one can understand that if there's a mutation in the protein that makes it bind more efficiently or tightly to the DNA, um, then that might cause an increase in function. And just to remind you, or just to show you how this works, is that KAT6A, so KAT6A or KAT6B, are part of a very large protein complex. And this is the zinc finger right here. And this is the enzymatic region of the protein. So one can imagine that an abnormality, as I said, in the zinc finger could keep the acetylation function of the protein. It, it'll acetylate the histone every time it attaches, which is not always the case. These complexes bind and fall off and bind and fall off. But if it binds and holds on tightly, there's a greater chance the acetylation will occur. So that's how you could have a gain of function. So just to, I think it's my last slide, so just to summarize the metabolic testing, uh, which we recommend for all children, at least at the time of their diagnosis. Indeed, most children will have loss of function. And of course, if a child has a mutation that has been reported before, that that I have studied, I have biochemical data to say this is consistent with loss of function, then sure might not have to do all the testing. But just because that one mutation in the winged helix region, which appears to be gain of function, even though it looks like a typical truncation mutation, shows you that the metabolism still looking at the child, looking at the child's biochemistry helps make sure about the diagnosis and also tells tells me how to treat each individual child because it's not one cocktail treats all. It has to be individualized, and one has to assess the metabolism of the child as on a regular basis, on like every year, every other year. And this is important because it's going to be years before any of the gene therapies and other approaches to treatment are going to make it to the clinic. And here we have well established tools that can be applied to KAT6A. Okay, thank you. Thank you, Gary. Just a couple questions before we bring the lot. And so starting Kelley, you have a workshop after lunch. Okay. And so you go in there. Yes, no, I'm aware of that. Yeah. So, most in trouble right now. Friends. We're doing a morning session here. And then everybody in the room to